This is poster 893. My name is Johan Jendle and I'm from Örebro University in Sweden. I would like to present to you the real-world effectiveness of insulin degludec in type 1 and type 2 diabetes mellitus from a Swedish societal one-year perspective. Today we have a number of RCTs as well as observational studies that have shown a lower risk of hypoglycemia when treating with insulin degludec compared to other basal insulins, both in type 1 and type 2 diabetes. The aim of this study was to assess the cost effectiveness of insulin degludec versus other basal insulins before switching to insulin degludec in a Swedish society one-year perspective in people with type 2 and type 1 diabetes. For this study, we used the REFLECT study, and that was a multicenter prospective non-interventional study performed in 7 different countries in Europe. It included both type 1 and type 2 diabetic subjects, adult, male and female, but they had to be without previous use of insulin degludec prior to be included in the study. You see here the outline of the study with 4 different visits over a 1-year period of time. From the REFLECT study, we took data on insulin doses at baseline and at 1-year follow-up. And you can appreciate that for type 1 diabetic subjects, the basal insulin dose was reduced by some 9%, the bolus insulin by 13%, and the total insulin dose with 11%. For type 2 diabetic patients, the corresponding values were -2, 4, and 3%, but they did not reach statistical significance. Moving over to hypoglycemia and the risk of hypoglycemia. Again, from the REFLECT study, it is noted that non-severe daytime hypoglycemic events had an incidence rate ratio of 0.85 for type 1 and 0.56 for type 2 diabetic subjects. Moving on to non-severe nocturnal hypoglycemic events, the corresponding figures are 0.63 for type 1 and 0.38 for type 2 diabetic subjects. Furthermore, for severe hypoglycemic events using the ADA criteria, the incidence rate ratio for this type of hypoglycemia was 0.28 for type 1, and due to low number of events, a former statistical analysis could not be made for type 2 diabetic subjects. Moving over to cost effectiveness then. Well, I would like to point out that for type 1 diabetic subjects, the cost per QALY is dominant. And that means that it's not only cost saving, it is also beneficial regarding the change in QALYs. And that is irrespective if you use the original price for insulin glargine or U100 or the biosimilar price for the same insulin. If we look at type 2 diabetic subjects, encircled here in red, you see that the cost per quality is some 15,000 Swedish crowns, which is roughly 1,500 euros for the original price, and 24,000 Swedish crowns for the biosimilar price in type 2 diabetic subjects. And this is well below the threshold for cost effectiveness, being 500,000 Swedish crowns. If we then move on and look at the cost distribution for type 1 diabetic subjects, we see that there is a total reduction in cost with 995 crowns, and that is mainly driven by hypoglycemia, but also to some extent less production loss. If we move on to type 2 diabetes and the cost distribution, you can see there is an increase in cost with 912 crowns. This increase is mainly driven by the cost for basal insulin, and the reduction in price is seen by hypoglycemia and also to some extent by production loss. So, to summarize and conclude this study, compared to previous basal insulin therapy with insulin glargine U100 priced as original or biosimilar, the switch to insulin degludec is cost saving in patients with type 1 and highly cost effective in patients with type 2 diabetes after 1 year from a Swedish societal perspective when using real-world data from the REFLECT study. Thank you.